protection plans. And the expected outcome is the participants have a clear vision on the different required activities for each step, all required activities and necessary steps for the development and implementation of a national action plan to protect health staff. Slide, please, next. Beforehand, we have four important remarks. If you see in this slide, the verbs are in the future because we developed this presentation many months before starting the recommendation to implement National Action Plan to protect health workers. So I'm going to use the past now instead the future. So the regional office of WHO and the hub provided very close technical support to countries for the implementation of different stages. It was also necessary to set up a practical organization between WHO hub and countries to ensure this close monitoring because we have had almost one meeting every week with countries for technical support about these activities. Presentation is also as part of the response to COVID-19. So we are mostly talking about the Committee for COVID-19 Response. And lastly, the appropriation of this project by MOH is critical for implementing activities because MOH have to lead the activities. WHO only for technical support. Next, please. Here you have WHO implementation model with 5 steps. We are going to review all different steps. To quote different steps, we have the step 1. The step 1 is the phase dedicated to the preparation of the action. The step 2 is the proceeding of baseline assessment. Baseline assessment is a situation of country before starting activities. The step 3 is the activities for developing and executing the action plan. The step 4 is the process for evaluating impact of your action plan. And the step 5 is sustaining the program over the long term. And it's a circle for the 5 steps. We are going to see every step by step. Next, please. And for each step, we are going to have 2 points. The first point will be to explain the recommendation of WHO about these steps. And the second point will be dedicated to the application to action plan to protect health workers. For the step 1, the preparation of the action. What say WHO? WHO says that you have to ensure that all prerequisites are in place before starting activities. And in this step, you have to define role and responsibilities You have, if possible, made available preliminary resources available, especially for holding meetings. And you have also to inform and sensitize all stakeholders. How to apply this recommendation to the personal protection enhancement project. First, the IPC committee meeting have to meet to develop an advocacy document for the project. This document should have the objectives, the strategies, the main activities, and the result for the project. Secondly, this will be a formal presentation of the document to the enlarged National Response Management Committee for project validation and also for ownership by MOH. And obviously, in this stage, as I said, it is preferable to have resources. Next, please. The second step is the basic assessment. What WHO say? WHO say to start the activities, after the preparation, the activities should be devoted to initial evaluation. It's a process and with inclusive assessment of the current situation with all IPC stakeholders. This activity should be very inclusive, using a recognized tool, in particular by identifying strengths, weakness, opportunities, and threats. And to say over, it is after filling the tool, you have to complete by a SWOT analysis. To apply these recommendations to the personal protection project, you have to fill a tool tree. What is a tool tree? The tool tree allows to assess the situation of protection of health workers in the countries. It's a comprehensive tool with 5 components: assessing a national program exists, assessing a multimodal strategy to prevent infection for health workers. It comprises also investigation of all cases and all exposures for health workers. It comprises also epidemiological surveillance and also early detection and management of cases. After filling this tool, you have to practice a SWOT analysis and identify all key strategic intervention needed for your program. Next. After this stage 2, you have to develop and implement action plan. Based on the result of initial assessment, you have to develop and implement an operational plan based on priorities, accompanied obviously by a monitoring evaluation plan. And it is, for the African context, it is very important to proceed to prioritization, because we have gap in all components of the program. The resource needs are very high, and all the resources are not available. So we have to prioritize in order to classify what should we do in the short term, what should we do in the midterm and what should we do in the long term. So in African countries, we need to have a good prioritization action. What about this recommendation for protecting health workers? You can design a small working group in charge of elaboration of the draft. But also you can also plan for a national workshop. For this plan, anything can be done. In the context of limited resources, we recommend a minimum requirement for health workers protection. Every country should at least develop epidemiological surveillance based on investigation on the ground. And if possible, regulation should be started on occupational infection health. The validation of draft by all stakeholders, IPC, should be done. The operational plan should be budgeted. This project should be validated by the national committee before implementation, monitoring, and evaluation. This is the step 3. Next, please. The step 4 is the process of impact. We are going, what say WHO? WHO say it is recommended to conduct a follow-up evaluation, assess the effectiveness of your plan, effectiveness on impact, of acceptability, and cost effectiveness. How to apply this recommendation to the protection of health workers. It is recommended to have a biannual evaluation of the action plan. So 6 months after the recommendation, proceed to the evaluation of effectiveness of your action plan, using the same tool as in the step 2. Here, you are going to proceed to the same activities as in the step 2, using the same tool, the tool tree, to assess the national situation of health workers protection. So if in the step 2, you find a performance, maybe for instance, a performance of 20%, because the performance has rated from 0 to 100%. If you find at the state 2, 20%, you should find more 6 months after, or maybe 1 year after. Because maybe some countries also will do the assessment maybe every year. And the result of this assessment should be integrated in the monitoring evaluation plan. And this impact assessment is used to correct all the difficulties, to update the plan, to improve the plan, and to go further and to have more positive result in your activities. Next, please. Step 5 is for sustainability of the intervention. The recommendation, general recommendation for WHO is to put in place an ongoing action plan to support the long-term impact and beneficial effect of the program, as well as in integration into the country's health system, will which will contribute to overall impact and sustainability in your country. And how to apply it to the personal protection. You have to develop a consolidated action plan based on the result of the evaluation, using all the gap or the problem identified in the evaluation. You have to strengthen institutionalization and sustainability of personal protection activities against the risk of occupational infection. You have to consolidate the regulation. And this regulation should go beyond COVID-19 and should include all occupational infection, as well as epidemic infection as Ebola, as COVID-19, as SARS-CoV, etc., but also endemic occupational infection such as hepatitis, HIV, etc. So we should take the opportunity of this pandemic to improve the protection of staff against all the infectious disease occupation. Next, please. We have elaborated a classification of countries according to where they are in the 5 steps. And this, in this classification, we have the step 1. In the step 1, we have 2 steps. 1A is for countries in situation of preparation and having not yet started any specific activities for the protection of persons. 1B for countries that have started specific personal protective activities, even partial investigation of cases of exposure or infection, and are preparing for a national situational analysis with tool 3. But in reality, it will be very difficult for distinguishing 1A and 1B because many countries said we have started submitting, etc. So it's very difficult, particularly English. In the other hand, it is very easy to distinguish step 2 because the step 2 is for countries that have already conducted the national situational analysis with tool 3. It is very easy to control because the source of verification is the result of the situational analysis with tool 3. So it's very easy to classify countries in the step 2. The step 3 also, in this step we have 2 sub-steps. 3A is for countries that have already developed operational plan, monitoring, evaluation action plan, based on the results of the situational analysis with tool 3. Here also it is very easy to distinguish countries because the source of verification is objective. It is the physical presence of action plan. The stage 3, step 3B is for countries that have already started the implementation of the operational plan with production of regular periodic reports. Here also it's very easy to classify according to the report of activities for implementation for monitoring activities. And in the steps 4 and 5, these steps will correspond respectively to the evaluation of the operational plan using the tool 3 and the implementation of the consolidated plan for sustainability. Next, please. Here in this slide, you can see the situation of African countries according to the 5 steps as of 30th of July 2021. And as you can see, you have in many countries, we did not get any information. It's really challenging to get information from countries, especially for health workers infection, which is a topic very sensitive. We have around 90% of countries being in this step 1, A and B, but sometimes difficult to classify. We have 8 countries, 17% in the step 2. And we have only 3 countries, 6% in the step 3. So the situation was not very advanced in Africa. We have, again, many things to do. The gap are used for the protection of health workers. Next, please. But if the resurgence with the African team, IPC team, continuing to close monitoring, very congratulations to people in the hub who are very continuing despite the use of the gap. We have got some change in the last weeks, as you can see in this slide. For instance, in Senegal, the MOU agreed in the principle to implement an operational plan developed, because we have an operational plan developed under the technical support of WHO. But it's just an agreement in principle, because we did not see anything in the ground. In Zimbabwe and Kenya, they just received the fund for the implementation of their operational plan, because they developed an operational plan. In Central Africa, they have sent a technical proposal that will trigger the release of necessary funds for the validation workshop and implementation of the operational plan. In Uganda, the tools were contextualized and the country started the implementation. But there is not yet a concrete action plan with systematic data collection. Seychelles and Namibia are reviewing and contextualizing the tool before implementation. In Malawi, digitalization of the risk assessment and case investigation tool was born and planning on rollout. In Ethiopia, they are doing in the field, but the resources are still requested for optimal rollout of the activities. So, since the last presentation, we have some change. Even it's not really very significant, but we have some change. Next, please. The prospect. As you can see, all countries should use the 5-step approach as a roadmap. Each country will progress according to its own realities. So each country is unique based on its own context. For WHO, this approach could be used to monitor the progress of the project at each country level. We should not also that this is a priority strategic intervention both for WHO and for countries, and its implementation should therefore be considered in the short term, as we are still in pandemic and the staff need to be protected. It can be done either as an isolated intervention or as part of the implementation of minimum IPC requirement, because as you know, we have a project to implement IPC minimum requirement in some countries in Africa. Over, I think it's the last slide. Thank you very much for your attention.
Thank you, Prof. Babaka, for that very informative and insightful presentation, and especially on the fact that this stepwise approach can actually be adapted and contextualized to meet the specific country setting. And then our next speaker, I'm going to invite Mrs. Azin, who is working with Africa CDC as a pharmacist and is working under the Save Lives and Livelihoods umbrella in the Africa CDC. She's here today to talk to us about the vaccine rollout status in Africa. Azin, over to you.
Good afternoon, everyone. My name is Administered. I'm the vaccine program coordinator for Africa CDC. I will share my.
Sorry, Azin, you are not audible enough.
Okay, so I'm going to share my screen, and can you hear me better now? Can you hear me better?
No, Ezine, your voice is still a bit low. If you can please maybe move closer to the mic.
Or you remove the earpiece.
Okay, so is this better?
Yes, perfect.
Okay, yeah, okay, thank you very much. Sorry about that. So I'm sure you all can see my screen. So today I'm going to take us through the landscape for vaccination on the continent, where we are and what the analyses are, how countries are doing. So as at Monday, which is when we collect our data, the vaccine supplied on the continent stands at 163.6 million. And out of this, 120.2 million has been administered, which is a quarter of the supply. And so that tells you that vaccinations are actually going on and people are taking vaccines. And for fully vaccinated on the continent, we stand at 3.49, almost 3.5% of the population has been vaccinated. The number is pretty low, but in the past 2 weeks, we've seen some significant increase in the projection and in the trend of which is going. And that's 46.7 million people on the continent fully vaccinated. So looking at the type of vaccine used, this is just like a global picture of where vaccines, the kind of vaccines that are where and how. This next slide gives us a better understanding to tell us that the most vaccine used on the continent is AstraZeneca, followed by Sinopharm. And you can see AstraZeneca being used alone in 4 countries, AstraZeneca and Sinopharm in 5 countries, and there are various combinations. Almost all countries are using more than one vaccine on the continent. So there are combinations. There's no country that is using J&J alone. J&J is used with others. Sinopharm is used with others. Sinovac is also used with others. So looking at the percentage coverage for procured amounts, this is looking at what percentage of the procured vaccine amount is of the population. So we don't have data for 2 countries. As we are aware, Eritrea and Burundi have not started vaccination. Burundi is in the process. They've actually requested for doses from COVAX. So soon we are going to start having data from Burundi. So most of the countries in the continent between 0.1 and 10%, and that's 36. And we have 14 between 10 and 35. One, which is Morocco, is between 35 and 60. And then you have Seychelles and Mauritius greater than 60% procured. Then for coverage administered amounts, this is what percentage of what has been administered is of the population. So we still don't have data for two countries, and the bulk of the countries on the continent are below 10% coverage administered amounts. That's 42. We have 8 between 10 and 35. And then we have one country, Mauritius, Morocco at 35 to 60. And then two countries, Seychelles and Mauritius, still at greater than 60% of population have been administered with the vaccine. So these are absolute numbers of what's the quantity of vaccine that has been used by countries. The darker the color, the more vaccine has been used in the country. So, and you can see that the darkest of all is Morocco, and then that's followed by South Africa and Egypt. And then you have other countries between 17, between 1 and 10 million, and then 30 between 50,000 and 1 million, and 3 between 1 and 50,000. And those are really small countries. So I just wanted to point out, this is not to call out any country, but just to show countries that have used most vaccines and the ones that have used least vaccines administered, and also looking at their percentage of fully vaccinated. So for the top 5, we have Morocco, South Africa, Egypt, Tunisia, and Zimbabwe. And you can see the quantities that have been used in these countries. And this gives you a picture of what is being used in the rest of the countries. And also looking at the percentage fully vaccinated, Morocco is at 45.17%, which is almost going to almost 50. South Africa is at 16.97. Egypt is at 4.15, despite being one of these that have been administered most. So population also plays a role in percentage fully vaccinated as well, because Egypt is a very populous country. And we have Tunisia and Zimbabwe following. So for those that have used the least number of vaccines, we have Djibouti, South Sudan, Sao Tome and Principe, Guinea-Bissau, and Sahara Republic. For Sao Tome and Principe, it's actually because it's a small island. That's why it's on this list, and it's managed to actually have a high percentage fully vaccinated, which is 5.94. But you can see the figures for the rest, and these are countries that we are hoping to support to increase the vaccination rates. So looking at giving a full picture now on the continent of where different countries stand, we have about 7 countries that for fully vaccinated percentage is greater than 10. That's Seychelles, Mauritius, Morocco, South Africa, Tunisia, Eswatini, Zimbabwe, and Equatorial Guinea are the ones that are more than 10%. But then you have this whole list of countries, which is where the bulk of the countries are, between 1% and 10%. You have countries like Botswana, Rwanda, Gambia, Sao Tome and Principe, Namibia. You can read the list and see which percentage fully vaccinated is in the country. And then we have those that are less than 1%. And there are some countries that are really not doing well. You have countries like DRC, Congo, where population, again, plays a huge role, because DRC is a big country. Even though their vaccination rates are low, it's going to affect their percentage fully vaccinated. And then same thing with Ethiopia as well, because of a huge population, and it's going to really affect the percentage fully vaccinated. So population, as we're looking at this percentage fully vaccinated, we have to consider the populations of these countries and interpret accordingly. So this is an overview of the data for fully vaccinated. And then type of vaccine acquired how. If you're aware or not aware, there are 3 mechanisms through which vaccines are coming into the continent. There's the COVAX mechanism, there is the bilateral agreements, and then there is the AVAT mechanism. So the first one being the COVAX mechanism, which is a coalition of different partners that was set up way before the outbreak started. So you can see the vaccines that are being delivered through COVAX. Majority of it is AstraZeneca, followed by Pfizer, then you have some J&J coming in as well, and Moderna is also in the portfolio. Then you have that's for bilateral. This is what the picture looks like. So bilateral is when countries buy directly either from manufacturers or they buy from, or another country donates to them directly. So we've had AstraZeneca also, then Sinopharm, Sinovac, the very popular ones here coming from China. And then we've also had Sputnik V from Russia. And we've had Pfizer and J&J also coming in as donations to countries. And then lastly, we have AVAT, which is a mechanism that was established by the African Union in collaboration with other partners. So we have started distribution as well. Earlier in the year, we distributed AstraZeneca to about 10 countries, to about 13 countries. And then last month, we started distributing J&J distributed to about 12 countries as at the time of this report, but now it's up to 21 countries that were distributed to. So this is an overview of what is the percentage of vaccine that is being used on the continent. So majority of what's being used is AstraZeneca in 47 member states, which stands at 39%. Sinopharm is the second at 28%, being used at 35 member states, followed by Pfizer, used in 9 member states. Then you have J&J, which is used in 32 member states now. Then you have Sinovac, 40 member states, Moderna in 5% in 5 member states, Sputnik V 1% in 9 member states, and then Covaxin is being used in 2 member states. So this is how it's being broken down on the continent, and you can see the popular vaccines are AstraZeneca and Sinopharm, taking more than a quarter actually of the vaccines being used on the continent. So just to wrap up, these are the vaccines breakdown by the 3 mechanisms. So for COVAX has been received, or vaccines have been received through COVAX in 47 countries, and that's about 60.3 million. And then for bilateral, 46 countries, and that's almost 100 million. And AVAT, which is majorly J&J, the single dose J&J is at 3.9 million. Then this is just a rundown of the AVAT doses that we have distributed to 21 EU member states, and over 4 million doses have been distributed of J&J doses have been distributed, or about 4 million. So this is the overview. The bulk of has gone to Egypt and Nigeria. So countries request when they are ready, and we send to them the vaccines. So just to give an overview of how the trends of the vaccines are going. So this is how it's been in the last 4 weeks. There was an upward trend in the ending of August, and we're seeing a downward trend last week. And this is for first dose. And then looking at also for second dose for the continent, we've seen a drop in vaccination rates, and I'm hoping that by the time we do the analysis for this week, we're going to see an upward trend. So that's all from me. Thank you, everyone, for listening.
Thank you, Zin, for that very informative session on the overview of the vaccine rollout in Africa. And, as we can see from what she was presenting, we still have a lot to do in terms of creating awareness so that our populations get to be vaccinated. Please note there was a typo error in the chat box. Kindly put your questions in the chat, in the Q&A box, as we will not be able to attend to raised hands. So at this point of time, I would like to thank our presenters and hand over to Dr. Wande, who is going to lead us in the Q&A section. Dr. Wande, welcome, and over to you.
Thank you very much, Lizzie, and good afternoon, good morning, colleagues, depending on where you are joining us from. Just before we go into the Q&A, we will take about 3 minutes health break for our interpreters, for them to grab a glass of water, because the discussion is going to be a bit interactive. So we'll give our interpreters about 3 minutes just to get a break. Then we will start the Q&A session almost immediately. So please keep your questions coming and put them on the Q&A box. We unfortunately will not take questions from the chat box. Be sure to use the Q&A function. So great, welcome back. And now we will have our moderated discussions, answering some of your questions and comments. I see that some of my panelists have already started to type their answers. As a start, I'd like to welcome representatives of WHO Afro, from ICAN, as well as Africa CDC, who will be on my panel today, and of course, our esteemed speakers for today. Just as a start, Prof. Babacar, this question is for you. It says, what are the key strategic interventions applied and recommended by WHO? So Professor Babacar, over to you. And I think it's a two-part question. There's another follow-on question that says, the key strategic interventions applied and recommended by WHO in step 2 modality. So I think there are two groups of people that want to understand what the strategic interventions are. So over to you, Prof. Babacar.
Thank you very much, Dr. Wande. I understand well, because my English is not very strong. They're asking what are the key interventions recommended by WHO for implementing activities, IPC activities.
Correct.
So it is the title of my presentation. So when you have a strategic intervention to apply in country, for instance, you want to set up a program for hand hygiene, or you want to start intervention for improving health workers protection. you have to follow different steps. And WHO recommend to have 5 steps. The first step is to prepare the action. And what to do to prepare action? You have to set up all organization to be in place, role, responsibilities. You have to prepare the resources. You have to inform, to sensitize all the stakeholders about the project. So this phase is called preparative phase. It is the step 1. After having do all these activities, you can start. You start with the step 2. The step 2 is for assessing the situation before starting the project of hand hygiene. If it's a project for hand hygiene, the situation of protection of health workers. Your aim is to protect health workers, etc. And for many processes, you have different tools for the assessment. And the step 2, where is also a question about the step 2, how to do it. The step 2 for assessment is to use a tool. For hand hygiene, you have a tool, hand hygiene self-assessment tool, and for protection of health workers, as I said, and I described also the principle of the tool tree, which is to check the activities on different components of health workers protection. We identified at least 5 components to protect health workers. You should have a program for protecting health workers. You should have different preventive activities using multimodal strategy to prevent infection in health workers. You should have activities for investigation of health workers' exposures and health workers' infection. You should put in place a system for epidemiological surveillance of data from the ground, interpretation, analysis, etc. And at least you should also have a national policy for early screening of cases in health workers and management also of health workers having an infection. So for this step 2, you have to fill the tool in the objective manner, and the tool will give you the performance of your country about the process. And this performance will be followed with your M&E plan. I don't know if, but I can speak 1 hour about this question, but it's not, you cannot, because only in the tool tree can have 1 hour training, and there are many things to do. Over to you, Dr. Wanda.
Thanks so much, Prof. Babka. I understand that that question is quite layered, but I think you did a fantastic job trying to at least summarize it. So AVAT has another meeting, and I see quite a number of questions for our presentation. So what I will try to do is answer a few questions, then we'll come back to the other questions. So AVAT, one of the questions addressed to you is, we have people vaccinated with AstraZeneca, but they don't have their vaccinations recognized by some European countries as well as the US. What can be done and what are the implications going forward? Over to you, Ezine.
So
I'd just like to say that this question has been raised a lot in so many briefings. And the issue we all heard when the EU said, oh, if you don't have this type of AstraZeneca, we're not going to let you come into our countries. But because of the outcry that came out as an aftermath of that, the EU has allowed countries to decide for themselves. So a lot of countries are actually recognizing AstraZeneca now, no matter which brand you got in the European Union. So it's a continuous battle too, because it's not fair, because this is what we have here on African nations or African citizens, to tell them that you can't travel because I got COVID vaccine that is different from the one you got, because that's what is available. So that's the same vaccine equity we're talking about. So the one for the EU, the situation is getting better as countries are allowed to now make their own decision, and many of them don't mind what vaccine you got as long as you got vaccinated. So, like I said, it's a process that's continuous. We need to keep lobbying to ensure that as long as you're vaccinated, you can be allowed to travel. And we also know that the IHR instruments, which all these countries signed onto, does not permit restriction of travel based on issues like this. So, and it's also going to be very poor on economic growth and human movement if we continue to push for things like this, or like segregate and stigmatize over the kind of vaccine people got. Over.
And thank you very much. There is another question around initiatives for local production on the continent. I know that there are quite a few hubs based on some of the agreements that the continent is making with the global north and encouraging local production in Africa. So there is a question around that. If you're happy to just talk a bit about the few hubs that we have on the continent, I think that would be very helpful. Over to you, Ezine.
Okay, so yes, there's been some progress made in the area of manufacture on the continent. First, there is a body established called the Partnership for Africa Vaccine Manufacture to help push this agenda forward and make sure that we have more vaccination and production hubs on the continent. But as it is already, there are some local manufacturers or patent holders that are already on the continent. For starters, we have in Egypt, we have in Algeria, we have a plan in Morocco, we have a plan in Senegal, we have a plan in Nigeria, and we also know that the J&J that we're all getting now was the fill and finish was done in South Africa. So there's been some progress, and these are different vaccines. In Egypt, we have the Sputnik V, and we also have Sinopharm, the plan to build a Sinopharm vaccine manufacturing. And then for Algeria, we have fill and finish for Sputnik V, and then for Sinovac. So the same goes for all the countries in the northern region. The Morocco and Senegal plans by next year to start production, same as Nigeria, to start production by next year. And so you can see that there has been some progress, and we hope that through this initiative of the Partnership for Africa Vaccine Manufacturing, that we're going to have more and more countries come on board. Over.
Great, thank you so much, Ezine. I'm just trying to make sure that you're able to take some of your questions before you get off. I don't know if you'd like to also talk about guidance. I'm quite aware that at least in normal settings, what we encourage is for 2-dose vaccines, for example, that you stick to the vaccine you got the first dose of, as opposed to mixing. But I see a number of questions around mixing or using different sort of vaccines. If you'd like to talk about that and the recommendations that your team gives, I think that would be very helpful. Over to you, Ezine.
Yeah, so that's actually a real problem, because some people, when the war started, almost every country had AstraZeneca. And now we're now seeing countries come up with Sinopharm, come with Sinovac, with J&J and all whatnot. So we don't really advocate for mix and match. We rather you stick to the 2-dose vaccines that you've gotten. But really, in a situation where it's unavoidable, I think there is nothing anyone can do, but we do not advocate for one to actually start mixing and matching vaccines. You take AstraZeneca and Pfizer, at least right at this moment, we don't have enough evidence to back that up. So just stick to the 2 doses of the same vaccines you've gotten, or you stick to the single dose of AstraZeneca. Do not go looking for something to boost the AstraZeneca because it's single dose, and that's enough. But in situations where you can't do anything about that, sometimes one dose actually is efficacious. It's just that with vaccines, 2 doses give you more protection. So that's all I can say about that. I don't know if other panelists want to comment.
Thank you very much. Just because you had to go, we decided to put you on the hot seat. Just one last question for you before we move on to the rest of the questions that the experts on the panel will answer. It's around adverse events following immunization. With the popular vaccines that we have on the continent, based on the information that you have presented, AstraZeneca and Sinopharm. So this participants would just like to know, in terms of the reporting on the continent, what are we seeing when it comes to adverse events following immunization? Over to you, Izzy.
So ideally, we should have data for this, but unfortunately, not many countries are reporting well for these and countries are actually not disaggregating. We're just reporting, oh, there was an adverse event, and we're not sure what vaccine was the cause of the adverse event. So there's a reporting gap in that area. We know that there are adverse events happening, but the disaggregation isn't happening, and that's something we need to talk with countries about to make sure that at least we can make more informed decisions based on what the information they've shared. But unfortunately, as at this point, it's not really being disaggregated, and that's very unfortunate.
Thank you very much. I think you've done a fantastic job. I'm taking a good chew at all of these questions that have come for you. Thanks for joining us. I know you have to get off now. Thank you to other panelists who on the call. I will start, Prof. Babka, I will come back to you because I also have quite a number of questions for your presentation. One of them that has come out strongly is, I think a lot of our participants want to know how other African countries are doing in terms of the progress on the operational plan. And why we are not seeing some of those other countries. I think one of these questions says, does this mean they are not being, does this reflect their level of responsiveness? Another participant has flagged that they do not see Nigeria on the progress report from your presentation. So, Prof, if you'd like to take a go at this before we move to the next round of questions.
Thank you very much, Dr. Wande. As I said during my presentation, data about infection of health workers are very sensitive data. And some countries are not sharing this data, especially countries where WHO do not have a focal point in the country office. So we cannot publish data with the country do not agree. So among the 57 countries for which didn't publish any data, we are sure some are doing some activities. I want to talk about Nigeria, for instance. In the beginning of this project, we have had many collaborative activities in Nigeria because there was a national IPC focal point in country office in Nigeria, and we did many activities together. But since the end of our contract, we didn't get any data, so we cannot publish. I can say about that. Over to you.
Thanks, Professor Babaka. I think that what I'm hearing from at least two of my speakers is there are concerns around data sharing. Some of the information that definitely would go a long way in driving our interventions or understanding some of the challenges the continent is facing. It's a bit challenging because we are not getting enough or sufficient data in this regard. So thank you very much, Prof, for at least making a good effort in addressing that. On the issue of not having enough data, Ariyo, I see there's a question around the EPI presentation around we are missing South Sudan on the list. Is it that there's no data available or what? And I see that you are flagged that you would like to answer that question. So over to you, Ariyo.
Yeah, thank you, Dr. Wande. South Sudan is reporting, and the only problem or the only challenge that we had is that the slide for this webinar was prepared early today, and they've not sent today's report. That's why they are not appearing on the update for today, but they will still send their report today. Over.
Thank you. Thanks very much, Ariyo, and at least that's good news that we are able to get at least the epidemiological situation as to the best of our ability. There is an important question, Prof. Shade, if you would like to take a stab at this. I say this because this is something that has come up over and over again in all of our webinars since we started the rollout of vaccines on the continent, is around vaccine hesitancy. It definitely is a serious problem, particularly around healthcare workers and frontliners. Are there any strategies that we can think about using, at least for the healthcare workers, which we are working with, to encourage more of them to come out and take their vaccines? Over to you, Prof. Shade.
Okay, thank you very much. A lot of what I have found about vaccine hesitancy amongst healthcare workers actually is that there is a dearth of real information amongst a lot of them. There is a problem with the understanding of the science behind vaccines and how these vaccines were developed. And sadly, a lot of healthcare workers are also listening to the internet. So some of the things that have sort of, when I say that have changed minds, have been when we discuss the science, explain and remind people about how the immune system works and what the vaccines are. Essentially, vaccines are like an artificial, for us, an artificial introduction of parts of the virus and allowing your body to take control and produce the antibodies that will fight it. I mean, that's it in a very crude, so and the issue for them is there are two other issues. Is it safe? Was it done too quickly? And there are answers to that. And also, are there some that are inferior to others? And what is coming out is the differences are really not that significant. And all of them are protective and prevent you from getting severe infection. Is it that we don't want any infections at all? It would be nice, but a lot of the vaccines, if this vaccine prevents you from going into hospital and dying, then it just becomes it turns COVID into just another disease. So the vaccine works. So there are answers. For example, some of the greatest problems, even for healthcare workers, is that they were developed too fast. What we forget is that the science of this had started a long time ago for cancer research and so on. So it was really now a step, in this direction. It was a higher step. And then there have been other SARS-CoV viruses that people had been working on. So that we got the vaccine out in a great time were two things, apart from the fact that it's not new science, it's just that we bumped it up for the vaccine, for this particular disease, was also that we had a huge number of people who were ill, so that some of the tests that would take years to get the numbers to get your results could be done, could be achieved in a short time because of the high infectivity of this virus and the rate at which it was spreading. And then stage 2 and 3 were done sort of pari passu. So the information is not inferior. And any vaccine, whether done under these circumstances or before, you would still go on to check when it is in normal use to see how it's happening when you're rolling it out. Again, COVID has given us a lot of material to work with. There are just so many people that are infected that you can't get some of these. You know, the transmissibility of this virus has also allowed us to have populations to work with, whereas we may not have had that in other times and with some other diseases that are not so that are not easily transmissible. And if you think about it, the Ebola virus again came out because we had the 2014 Ebola infection, because it affected huge numbers of people. So you could do some of these tests without, which would have taken more years. That would it change your DNA? It doesn't get integrated into your DNA, because for it to get integrated, it would need that you have added to these vaccines the integrase enzyme and other enzymes that would allow it to cut ligase, that would allow it to cut the DNA, insert itself, and then it doesn't happen. So they just, I think for healthcare workers, we may need to produce the evidence and give them the information. We're beginning to see chances of dying from COVID is very low. Your chances of hospitalization is extremely low. So some people say, oh, they are using us for guinea pigs. Oh, then it means that they've used us for guinea pigs for polio vaccine, for smallpox vaccine, for yellow fever vaccine. I mean, they haven't killed all our children that we give vaccines. So what's changed? So I think we just need more information, and we need to keep bringing out the science and explain the science in simple language with analogies that address this. Unfortunately, social media has done a lot. And I think some of that is coming from some politicization of the vaccine story. And some of these people have spent a lot of money trying to make myths and propaganda look like facts. So there's a lot of work we need to do in that direction. Thank you. I hope I've helped a little.
Thank you very much, Prof. Thank you. That was really fantastic response to that. I think what I would really like to take from that is, despite the fact that we are dealing with a new virus, we have had years and years of science, of improved science, for us to have been able to develop a vaccine in a short time. So I think if we're going to take any message back as healthcare workers to the community to encourage vaccine uptake, is new virus, but we have had decades of science, of research for us to have been able to get this to this stage. So yes, the thing, humanity has advanced, and that's why we are able to develop this and develop vaccines in a short time. So I think that's a message for us to all take back. New virus, but good experience, years of experience of science for us to be able to develop this. So thank you very much. I'm to Aria and Professor Babaka. I see your hands are raised, but what I'll try to do is, since I have a few questions for Professor Babaka, I would let you give your intervention when I do ask that question. We have a question, Lizzie. This is for you around a bit of the housekeeping and the certification. This question is trying to understand how many weeks make up a series. What is the minimum attendance for people to qualify for their certificates? I know you did it when we started, but I think a few people have joined very recently. So Lizzie, over to you.
Thank you, Dr. Wande. So we are currently in series 9, And each series is made up of 6 sessions. It is, so in a total, you have to attend 6, if it means you are attending 100%. But for you to attain a certificate of attendance, you have to at least attend 4 out of the 6 sessions. And you are also required to have stayed online for at least 1 hour. And then you will all receive that is, if you meet the 2 criterias, you then receive the certificate of attendance at the end of the series, that is after week 6. And then for the slides, they are shared in your the emails that you used to register. Thank you, and over.
Thank you very much, Lizzie, for that. Prof. Baka, we have a question for you. Quite a number of questions, but I will try to put them together so that you are able to take it, because we have about 5 minutes more. What is the percentage uptake of the 5-step approach in Africa? Again, coming back to the question on, are there countries that have not demonstrated interest at all? And again, for member states represented here, how do we get countries to demonstrate interest? For example, if a country X is interested at the moment, how do we contact WHO Afro to support in this activity? Over to you, Prof. Babuka.
Thank you very much again, Wendy. I think we have steps. How long it takes. It depends of, as I said, each country, each facility should be unique. All depends of the local context. So you have to adapt activities to your context. The preparation, it depends on resources, infrastructure, operational resources, etc. So there is no unique answer because of local context. But the different steps are always the same. The interest. The question is there some countries having no interest to the project? Is it right? So for this question, what I can say is we are having activities with countries, and I can say some countries are not attending this session. I don't know real decision not to participate or not, I cannot say, but what we can do is to present the countries with which we are having activities and to present the results. I cannot say anything about the other countries, but we are trying is to get all countries of the continent, and it is the same for countries. If our countries have interest in this project, they can contact the country office of WHO, and all countries are welcome in this project. What I wanted to add about vaccine hesitancy from health workers is in each epidemic or for each occupational infectious disease, the target should be to have all health workers vaccinated. And it's also an occupational medicine problem. So we should involve the occupational department and also the trade union. These stakeholders are in the best position to work, to talk, and to deal with health workers, and their involvement is critical to have the adherence of staff on vaccination. Over.
Thank you very much, Professor Babka. I think that's a really nice angle that you have brought in healthcare worker protection. These are really our frontline experts keeping us safe, and as such, we must keep them safe and keep them protected. So thank you very much. So thanks, Izine. Just let us know that she is back and has. I would like to take at least I think some of the questions at least with one answer at a go. So Izine, over to you before we wrap up this Q&A session.
Okay, thank you very much. So going through the Q&A chat box, I saw this question a whole lot. Can I take 2 doses of AstraZeneca and 1 dose of J&J? Can I take 2 doses of J&J? Can I take a combination of... Doing that doesn't make you any different from these global south that is hoarding vaccines, or people who are hoarding vaccines, or where we're not getting enough vaccines. Science has shown that 2 doses of AstraZeneca, 2 doses of Sinopharm, 2 doses of the 2 doses of vaccines is enough to protect you. And 1 dose of J&J is enough to protect you. So do not think you're doing yourself any great by combining different medications. It's like when you're told to take 2 tablets of paracetamol, it's enough for you when you decide to take 10 and then you're damaging your liver. I'm not saying that this is going to kill you, but the thing is, science is, this is something as Professor Shade was saying, science, I mean, the science is there. So let's not, out of fear, start thinking of mixing and matching vaccines just because it's available now and because we think it's going to give us better protections. Let us leave enough. Take the 1 dose that you have to take, or the 2 doses you have to take, so that the other person also can get. We don't even have enough on the continent. So just take the quantity you've been told to take. If it's 2, you take 2. If it's 1, you take 1, so that your neighbor can also have enough vaccines to take for he or herself. And that's just what I want to talk about, because it's coming up a whole lot. Please do not take more than you're supposed to, so that others can also get. Thank you.
Thank you very much. We have had a very interesting discussion. What we are taking, in addition, a take-home message is we need to look out for each other. There's no benefit in taking more than as nationally prescribed. Like we always say, the best vaccine is the vaccine available to you. But at the same time, as you are coming out to take your vaccine, you must take the stipulated dose as recommended by your national government. Don't make the scarcity worse than it is. Be responsible by taking the required dose as prescribed globally at by the national government. So I think we are slightly 2 minutes over, but you would agree with me that this has been very insightful. So thank you very much to the experts who have joined me on today's panel. I look forward to next week's session and hoping that we have also an interesting and engaging moderated discussion. So thank you very much. Over to you, Lizzie, to wrap up the session.
Thank you so much, Dr. Wande, and thank you to our presenters, the panelists, and a special thank you to the interpreters and also everyone who managed to join in today. So we hope to meet with you again next week in our next session, and also encourage those who haven't yet joined the community of practice to use the link that has been provided on the chat box, and also for you to get the information, you can log into the Africa CDC, the ICAN, and WHO websites to receive up-to-date verified information on COVID-19 and also on IPC best practices. And thank you, everyone, and we'll meet next week. Bye.
Thanks,
Thank you very
bye.
much, and bye.
Recording